Let me tell you something. I want to give you something to think about. It's a number, a big number, about 475,000. 475,000 isn't just a number, it's people. People who died from cardiac arrest in 1 year in the United States. Big number, bigger opportunity. Because we can get that number down to zero. We can save all those lives. We can create a world where no one dies from cardiac arrest. Am I dreaming? No, I'm not a dreamer. I'm a visionary. And I'm asking you to be too. I want you to see it first, that world, and then do your part to make it happen. I need you to believe in your heart that it is possible. And then focus all you do, help focus all we do on that goal, on saving every single one of those people. Because we can do it. It is within our reach. How do we get there? You know how we get there. We'll create systems that automatically detect cardiac arrest and activate an emergency response. We'll mobilize an army of trained and prepared responders to provide immediate CPR and defibrillation. This means pairing 911 response with bystanders through mobile technology, ensuring public access to AEDs, and more training through schools and kiosks. We'll remove barriers to getting bystanders engaged, creating tri-standers in the general public. We'll eliminate preventable cardiac arrest in hospitals using monitoring for early detection and rapid response teams that will stabilize patients immediately. We'll make sure all healthcare providers deliver high-quality CPR with innovative quality improvement tools and sessions. And finally, we'll personalize resuscitation to each patient, leveraging the latest technology to identify and treat underlying causes. To get that 475,000 down to zero. It starts with you right now. You're doing good work. We do good work that has laid the groundwork for us to be truly extraordinary. Believe in the vision. Let it drive everything you do each day. Let it rise up in you like a shout, joining the voices of your colleagues, teammates, neighbors, and family. And then look around. See that number start to decline, life by precious life, bit by bit, until that one glorious day when everyone who would have died before all this work instead wakes up groggy and thankful in a hospital to greet his or her family. And we arrive gloriously at zero. Because of you. Because of our vision, a world where no one dies from cardiac arrest. Let's get started.
Please welcome to the stage Nancy Brown, CEO of the American Heart Association.
Good morning, welcome, and thank you all for being here today. And to those of you on the live cast, we have over 2,000 participants from 31 countries joining us live today, and we're just so grateful that you are here. This is a really important day in the life and the history of the American Heart Association. As we just heard on that very compelling video, we have a problem. 475,000 people a year in the United States and 6 million people a year globally die from cardiac arrest. This is simply unacceptable, and it can be changed. And as part of the guiding values of the American Heart Association, where we intend to meet people where they are and to make sure that there is no inequity for delivery of health care, and health services, not just in this country and in the world, we are determined to do something new and different to make this problem go away. And as a matter of fact, the American Heart Association sees its mission to be a relentless force for a world of longer, healthier lives, and our vision to make sure that no one dies from cardiac arrest clearly fits into this compelling mission and vision of our organization. When we think about imagining a world where no one dies of cardiac arrest, we recognize that something new and something different has to happen. We know and understand that for this vision to become a reality, we have to think about how individual bystanders receive high-quality CPR and access to AEDs, and how our healthcare system uses new technologies and new ways to deliver training services to be able to make this vision and this goal a reality. And for any of you who have been in this situation, where you have been with someone who has had a cardiac arrest, or where you know someone who has suffered a cardiac arrest, in very few cases, these lives are saved. And in those cases, those individuals' lives are changed forever. But think of all of the people who don't have a second chance. Not just the poor individual and their family, but think of the first responders, whether bystanders, individuals in a hospital, someone in an EMS system. It's life-changing to either save someone's life or to not have been able to save someone's life. And what we want is, in every single case, for no one to have to die of cardiac arrest. And so we know that taking action person by person makes a tremendous difference. For example, the story of Christina, who's an ER tech at Salem Health. She received RQI training from the American Heart Association, and she used that training to save the life of a fellow runner who collapsed in front of her while she was enjoying a weekend. And we've talked with Christina, we've had Christina at American Heart Association events, and she talks about the fact that the RQI training of the American Heart Association made a difference in her ability to be able to administer high-quality CPR at the moment that mattered most. Think about Matt, who happened to be traveling at the DFW airport. He had time between his flights. He was able to use and learn CPR from the kiosk that we had placed at the DFW airport. And he saved Sean's life on a college campus after he collapsed from a cardiac arrest. Think about Paula, a nurse. She credits RQI training with helping her save the life of a patient who had a heart attack. And Ethan and his friends, who used the CPR skills they learned in high school to save their friend Dan's life. There are so many stories like this. And when you look at these faces, both of the person who survived and the person who was competent to administer CPR to these individuals who needed it most at this time, these folks have gone on to live happy lives, but they will never forget the power of what they learned from the American Heart Association. And across the globe, people trust the American Heart Association because we bring to bear solutions that are based in science, that are administered and trained with thoughtful ways to help people learn new skills. And people trust the American Heart Association because we don't stop at the science. We create advocacy platforms. So 39 states in this country, as a matter of fact, have mandatory CPR training as a high school requirement. We place tools and solutions in communities, and it's this broad portfolio approach that really helps to assure that people have the best chance at surviving a cardiac arrest. But I'm here today to say to you that all of us at the American Heart Association, including our volunteer president, Dr. Ivor Benjamin, who is in the audience today, believe that we are not doing enough. And as a matter of fact, we know that in the hospital setting, for an example, where in the US 200,000 people a year suffer a cardiac arrest, only 24% of those victims survive. This is unacceptable. We must do something new. We must do something different to change this trajectory. People are counting on us. They are counting on us to use our science. They're counting on us to use our relationships with hospitals in the US and around the world. And they're counting on us to look at new cutting-edge ways to bring solutions to the marketplace. And that's exactly what we intend to do. And when we think about making sure that hospitals and healthcare systems have the best tools to deliver evidence-based, high-quality care to every person, every time, it will require a new approach. It will require a new commitment. It will require all of us, who have the opportunity to participate in thinking about healthcare from starting with the patient and ending with the patient, to double down and do something new and different. And it will require us to build upon partnerships that have already allowed success to happen. When you think about what's going on in the news today, you hear about all of these very high profile, very impressive partnerships that are pledging to change healthcare for individuals in the United States and around the world. Whether it's the new healthcare employee health plan that Dr. Atul Gawande will run for Berkshire Hathaway, JP Morgan Chase, and Amazon employees, whether it's the partnership between Apple and Cerner on personal health records, or many other partnerships that you read about and you hear about. What I'm here to say is that we at the AHA have a long-standing and enduring partnership since 2005 with Laerdal Medical, where together we have trained more than 12 million people and we have saved millions and millions of lives. And today we pledge to take this partnership to a new level, to a new set of solutions that will absolutely allow us to get to the goal of making sure that no one dies of cardiac arrest. And here to tell you more is my friend and colleague, Tor Laerdal, president of Laerdal Medical.
Good morning. This event is about a joint commitment by the American Heart Association and Laerdal to help save 50,000 more lives from in-hospital cardiac arrest every year by 2025. With your help, that goal is fully achievable. It's a formidable number, and it may be difficult for most of us to relate to such a big number. It may be easier to relate to unique saves, like this 2-year-old boy. He was found head under the water. He had been floating with only kept afloat by a air pocket in his rain jacket, and he was discovered by his father after a few minutes. His father dragged him up, shook him vigorously, and was able to, after some time, some very long seconds, to make him vomit water and start to breathe again. This boy was me. The year was 1954. My father was a toy maker in Stavanger, Norway at the time, and he had just introduced the Anadol, which was the first doll to have natural stitched hair, sleeping eyes, and soft unbreakable parts. This lifelikeness made the doll very popular and an international success. In 1958, my father learned about the landmark research by Peter Safar and Jim Elam that proved the superiority of mouth-to-mouth breathing over previously used manual techniques. Having saved me from drowning, he now became almost obsessed about the idea of making a life-size, lifelike doll that could be used to train millions, not only healthcare workers and first responders, but also bystanders, to be efficient lifesavers. Since that time, it is estimated that 400 to 500 million people have been trained in CPR. And as a result of this, that at least 5 million lives have been saved. That's a formidable number as well. The American Heart Association has led the development of science in this field through decades. Lærdal has had the privilege of working closely with the American Heart Association in many areas, including the organization of several expert meetings at the Utstein Abbey that you see here, outside of Stavanger in Norway, to develop guidelines for how to measure, to improve, how to define a common language, how to define indicators for measurement, how to publish results, how to compare with colleagues and your own past performance, how to improve survival. Another landmark research was published in 2016 by Paul Chan, and this reports on using these guidelines for how to measure. This reports on survival from in-hospital cardiac arrest in the United States. And it shows a threefold difference in survival. So if you happen to have a cardiac arrest in one hospital, you may have a 12% chance of surviving. In another hospital, you may have a 38% chance of survival. And how is that possible? These hospitals have access to exactly the same medical science. They probably have very similar training programs currently. And they probably have very much the same equipment. Yet there is a threefold difference in survival. How is that possible? The Utstein formula for survival may be helpful. It's a metaphor developed at one of these Utstein meetings, but it may be helpful in trying to understand how that is possible. This formula stipulates that the chances of survival is a product of three factors: the quality of the medical science, multiplied by the efficiency of the education, multiplied by the efficiency of the local implementation. A position paper by the American Heart Association was published in Circulation last month, and that established what makes out efficient education. And it highlights in particular three factors, being high-performance CPR training with feedback, low-dose, high-frequency refresher training at the worksite, and more focus on competence maintenance rather than the past and current predominant focus on compliance. These three factors, if we relate them to the formula for survival, it is, I think, a fair assumption that the average hospital in the US today may have a high score on its access and awareness of the medical science, but maybe not have implemented these three critical factors for efficient education. And therefore, let's assume that they have a lower score of, say, 50% on these two factors. So this would yield 80% times 50% times 50% equals about 25% survival, which is what Nancy Brown described as the average situation today. 50,000 survivors among 200,000 cardiac arrests in hospital in the US every year. Now let's assume that we could change the situation and that we could achieve a higher score by implementing these three critical factors in most hospitals. And we could have an efficiency of 80% on all three factors. Then survival would raise to 50%. 80% times 80% times 80% makes 50 instead of 25% survival. In lives, that make 50,000 lives more. 100,000 survivors instead of 50,000 survivors. And that is exactly what this event is about and what you will hear more about in the next presentations. Thank you.
I'm Michael Lovelace. I'm one of the RQI administrators for our health system. And on April 13th of 2017, I was the recipient of RQI. I had a heart attack. I presented to the emergency department, was in denial that I was having a heart attack. I didn't think that it would happen to me. The realization happened when I presented to the emergency department. I walked straight back to one of the rooms where I know I'd have a doctor and a nurse, and they did my EKG, and they said, we're calling it. I was holding on to a nurse's hand, telling him I'm scared to death, and then I just drifted off to sleep. My heart actually stopped at that point. And I woke up about 18 minutes later, which I found out later that was 18 minutes that they were doing CPR to me. The nurse who was there with me was one of the nurses who had been trained with the resuscitation quality improvement device in the emergency department. And I have to believe that the skills that he produced on that day helped save my life by doing adequate and proper CPR. I'm here today to tell my story, how I believe that RQI helped save my life.
Hello, I'm Brian Eigel. I oversee our day-to-day operations of our RQI program. This is my driver's license. And I'm here to tell you, I am a great driver. I am a fantastic driver, and you can look at my license and you can see that. Now I'll tell you, my wife would disagree completely. She does not agree that I'm a good driver, and I show her my license and say, I'm a good driver. If you were to look at your license or hand your license to your neighbor and try to convince him or her that you are also a good driver, what would that license really represent about your ability to be a good driver? I think ultimately all it can really tell me about myself, and I think that you would know about your neighbor, is that you know how to drive. That license tells you that you know how to drive. There's no statement on there about whether or not you are a good driver. If you were to pull out your BLS card or your ACLS card or your PALS card, I stipulate and challenge us to realize that's exactly all that that card stands for. It says, I know how to do CPR. I knew how to do CPR on the day at which I was issued that card, nothing more. That's a problem, because ultimately we're teaching people how to do CPR, not to know how to do it, but to perform well. And so if you're a patient, what are your expectations by holding a card or holding knowledge? It's not just the patient expecting you to know how to do CPR. They expect to know for you to perform good CPR. And to get to this vision of zero, we can't know how to do CPR anymore. We must know how to do very good, high-quality CPR. So this is one of the problems. 2-year retraining is not optimal. The 2015 AHA guidelines made this extremely clear. 2-year retraining is not optimal. Went on to say that for healthcare professionals who are expected to take care of a cardiac arrest patient, more frequent BLS and ACLS and PALS training is absolutely necessary. The education statement that Tora mentioned goes on to say that mastery learning is essential for skills retention and avoiding skills decay. I'm not sure about you, but I think it was hard to think about almost anything in life where you could achieve mastery learning by doing something once every 2 years. I just don't think it's possible, and I think we have pounds of evidence to say it is not working. And this is really ultimately the fundamental problem. CPR skills decay rapidly. We all think we do a good job. Unlike my car driving example, there's no speedometer, there's no road signs, there's no GPS systems today, at least, on a patient telling us exactly what to do better and to do different. So in many cases, we do rely on our knowledge and our skills and our experience to perform our best. Fantastic. No one goes to work wanting to do a bad job. But we've been fooling ourselves thinking that we know how to perform very well when in fact, data is very clear. CPR skills decay rapidly. And a sobering thought is that in 1985, Beth Mancini and Bill Kay published a study showing us that within a year, CPR skills had declined. And their conclusion was, if a 2-year standard is to be maintained, retesting should occur annually. And if skills have declined, there should be immediate retesting and practice, hands-on practicing to get those skills back up. So we've known this kind of knowledge for 30 years. We've been missing, I think, technology and abilities to address this properly. And I would challenge us as a community to say we have perhaps been lacking some will to stand for performance, not knowledge. We know poor quality CPR is a preventable harm. We know what good CPR is, so we all know what good CPR is. Minimize interruptions to chest compressions, good chest compression rate, good chest compression depth, don't lean on the chest, please, and don't hyperventilate. So we know that. Knowing is the easy part. Doing this is so difficult. Doing this well, 2 hands, really difficult. Doing it with the team in an unexpected environment, very challenging. Again, to Tora's point, wide variability in the performance of high-quality CPR. That's the issue we're talking about, not intent. Every single healthcare provider goes to a patient and wants to save that patient's life. They are performing their absolute best. What we've been unable to do to this point is really help understand the tools necessary to allow for every patient, every time, to get high-quality CPR. And we know poor performance is devastating to patient outcomes. And again, it's about performance, not knowing what to do. That's a start. So knowing is good. Performance is even better. These 2 landmark studies showed us the gap in knowledge and performance on real patient cases. So we're no longer talking about whether or not I'm performing well at a mannequin or in a training situation. This is real life, real lives on the line. And the key here is that these healthcare professionals were well-trained, highly skilled, in systems that were absolutely dedicated and committed to improving patient survival as best as they could, both in hospital and out of hospital. And yet, despite those efforts of highly skilled, highly motivated, highly engaged healthcare professionals, 1/3 to 1/2 of the time, patients are still receiving poor quality CPR. And the challenge, of course, with this is, this was from landmark studies in 2005. So again, we've known, but not always really been able to adequately address the gap in knowledge and skills. So let's fast forward to the more current state. This is a recent study published by, I think, a brave and bold group of international collection of some of the world's leading pediatric hospitals in the United States, Canada, and Europe. And they wanted to also address and see how their performance is doing versus their knowledge. And again, these are real patients with absolutely skilled and committed healthcare professionals to save lives of kids. And again, as these researchers very bravely reported, most of the time, highly skilled, highly trained, engaged healthcare professionals were still unable to deliver high-quality CPR every patient, every time. We know high-quality CPR saves lives. We know it. Again, we have pounds of evidence that shows high-quality CPR saves lives. And is that performance that we're looking for every patient to receive high-quality CPR. It is the single most influential determinant of survival. Everything else after that, critically important. We've got lots of guidelines that talk about what to do once someone is come back to life. But high-quality CPR is going to be the determining factor for that. And so now we come back full circle. You say, okay, well, if that's true, then what's different? How do we get to different? And we have 50 or so years of thinking that we know how to do good high-quality CPR simply by having a card that says that's true. And again, many people are able to do high-quality CPR, but there is clearly a deficit. Hopefully the data I've shown you, and there's much more data that demonstrates that there is a gap in knowledge and performance. So I'm here to say it is no longer enough to simply know how to do good CPR, and it is not enough to think that you are a good driver, to think that you can do good high-quality CPR. We need to actually be able to demonstrate to yourself, to each other, that you can actually do high-quality CPR. So going forward, this is going to be the new, if you will, next higher standard of care that we are now rolling out and introducing here today. This idea of a verified competency in CPR, this BLS e-credential that actually stands for verified competence in CPR, achieved by low-dose, high-frequency quality improvement sessions once every 90 days, where you're going to actually go and prove to yourself, prove to others, that you are truly competent in the basic skills of CPR. And this now stands for, you can show this and now say, I know and perform high-quality CPR. This must be the new standard of care. It's the only way to get to the 5 pieces of high-quality CPR depicted in this picture, to actually prove and know that every time, every patient is going to get high-quality CPR. And this isn't just up to me or any other presenters or anyone else, except for everyone in this community. If you are a patient, what do you want the standard of care to be if you are in a cardiac arrest? To know that you're being taken care of by healthcare professionals who know how to do CPR, or those that can actually perform high-quality CPR every time? So now, this is an opportunity and a challenge for all of us to now take a stand and create the will for a new standard that is based on performance, not simply knowledge. But I do want to be clear. Knowing CPR, again, as both Tora and Nancy said, knowing CPR and performing CPR over the last many decades has saved many lives. So that's fantastic, critically important. Many survivors walking around on this planet today because they received good quality CPR from either bystander or a team of healthcare professionals. That is fantastic. We should need to celebrate that. But I dream of many, many more survivors that could be walking around if every patient, every time, got high-quality CPR, and it wasn't by chance that they happened to get someone who was really, really proficient. Every patient deserves a highly proficient system and highly proficient provider taking care of them. So now I would say, in the past, we may have known that skills decayed rapidly, but we didn't necessarily have a means to address that. Or we may have thought we didn't have a means to address that. Maybe we didn't have the right technology to help us address that. Now we know, now we have the technology. The only thing that's left is, do we have the will? Are we ready to change? Are we ready to give every single patient an absolute best chance at a second chance to survive and thrive? Thank you all very much.
So while going to the airport with my sister, who's a flight attendant, we were on our way to Miami for a trip. She dropped me off. She went to go park the car. I'm just walking in with my bags, and I just happen to look up and I see these people with a guy, and it looks like they're trying to help him to the floor. And I'm like, well, does he have a pulse? Because the gentleman looked really ashen gray. And just being an emergency room nurse, you know that there's no blood circulating and he's really sick. So I was like, no pulse, begin CPR. So I tell somebody to go get the defibrillator. When he get back, we actually connect the defibrillator to the man. We attach everything, and we do shock him, and we resume CPR because, of course, he didn't wake up. I really was thinking this is somebody's dad, somebody's son, husband. I saw a ring on his finger, and I was like, oh my goodness, you know, we've got to try to save this gentleman, because if that was my family member, I would hope somebody would stop and help them. Afterwards, the family got in contact with me, and they just wanted to thank me. Even the daughter was just like, you saved my dad. And I think to me that was the most emotional part. Realizing that I've saved a life just from my experience with RQI and as being an emergency room nurse, how much that's helped me grow and be confident. RQI is priceless. I'm Tamika Jones, a nurse at UAB Hospital, and RQI helped give me the skills I needed when I least expected it.
Hello, I am Russell Griffin. I am responsible for strategic research and innovation with the RQI program. We are living in one of the most incredible times in human history. The rate of innovation and technology, I would argue, is moving at the speed of life. And it's something as healthcare organizations, we have an obligation to be able to achieve, but not only achieve and sustain, but also exceed in the spirit of saving more lives. For that very reason, you've heard from Brian and my other colleagues about why we need to do this. I'm going to share with you today how we are going to do this. I am excited to announce that in January 2019, we will be providing our new RQI 2020 program. Millions of healthcare providers over the last 50 years have trusted us to provide training and advanced care courses for both adult and pediatric patients. However, to be candid, the logistics and the barriers of implementations and the culture that we have created of where is your card is not saving more lives. I would argue today, this is the old standard of care. We have placed the patient in the center of the design of how we have created RQI 2020. We consider that to be the focus point of everything that we do, and that is because of the full life-saving value of when you combine not only quality of CPR, but also quality of resuscitation systems of care and quality of teams cooperating, and also the quality of prevention of cardiac arrest, not just responding whenever the crisis occurs. With all this focus on CPR, you might ask yourself, why such emphasis? It's a tremendously low frequency but high consequence event where it's the patient's last chance for survival. Let me say that again. This is the patient's last chance for survival. That's why you see our all-in approach for a new standard of care. The paradigm of having healthcare providers in classrooms away from the patient floor where they do what they do best in caring for the people of our communities and delivering the highest quality of care must change. I realize that this has been the old standard of care. And while it has been transformative in the past, it will not sustain us in the future to be able to achieve the impact and bring home more family members that we know we can deliver upon. The time for us to change is now. When we place the center of patient in everything that we do, we must begin to focus on simulation-based mastery learning. We must begin to deliver on verified competence. We must be able to provide and ensure the healthcare providers have access to a platform that allows them to be engaged and active and provides them the feedback they require so each individual provider receives the tailored and customized feedback that's required to optimize their chance to save a life. This is the new standard of care. Many would say that practice makes perfect. And I would disagree. Perfect practice makes perfect. And we now have the technologies and we now have the ability to bring this full force across the spectrum of healthcare and ensure that providers are prepared to immediately respond and deliver the high quality CPR and other resuscitation skills that are required to achieve maximum survival. We are placing this where healthcare providers work, in the spaces they work, directly outside of patient care rooms, so we can ensure that just in time, they are prepared to walk in and save another life. This is the new standard of care. To improve, we must measure. We must have information, not only as the system, but also as the individual. With the technology we have now, we can provide tailored and customized reports based on each individual's performance that is objectified. It is not subjective in the opinion of another person, but it is verified data that provides reinforced and structured debriefings, achieving one of the milestones of simulation-based mastery learning. And while this debriefing is important and it's essential, I would also suggest this is more importantly a pre-briefing. I now as a healthcare provider am aware of what I need to improve on each time as I continue to engage and change how we save lives. This is a new standard of care. Probably one of the most exciting announcements that we have today is disruption of the paradigm of the way that you have always known us delivering content to healthcare providers across the spectrum. We have created new technologies that allow us to provide customized learning experiences based on your role in a healthcare organization, your position, the unit that you work in, your learning abilities. Through adaptive technologies and through predictive performance analytics, we now have the capacity to stop the one-size-fits-all model and provide content that is most relative to the providers who need it to meet their needs of the patients they care for. We have the ability to tailor the experience for the healthcare provider. This is a truly transformative time in our history when we can target healthcare providers in one unit of the organization versus another with specific details or information that truly bring to life not only the full capacity of high-quality CPR, but the complexity of advanced life support and the number of cases that we face in care every day. One of the greatest breakthroughs that we've had in the creation of new content has been the development of a new program that we'll be launching next year called RQI Responder. We believe, and I believe, if an individual was to collapse and have an unexpected sudden cardiac arrest anywhere on hospital property, regardless if it's the cafeteria or if it's the lobby, regardless if it occurs in the parking lot, that you would like to know that individual would at minimum have hospital employees who can recognize someone who has collapsed, activate the internal emergency response system, and begin high-quality, hands-only CPR until help arrives. We have designed the RQI Responder program to provide that blanket of protection to ensure that no matter your role in the hospital, we can ensure you are prepared to respond, bringing on that delivery that the patient is the center of everything that we do. This is the new standard of care. And one of the most significant disruptions since the formulation of advanced cardiac life support in 1979, I am excited to share with you today how we are transforming advanced resuscitation care practices for adults. I'm announcing today, next year we will launch our new RQI ALS program. And yes, that's very purposeful that we've removed cardiovascular from it. And you may ask why. We know for us to save an additional 50,000 lives each year that we must focus on more than just the immediate cardiovascular crisis, but we must also be inclusive of other clinical conditions that are the precursors that lead to cardiac arrest. And we can provide the information and the training that's more expansive to ensure that healthcare providers can recognize these conditions, intervene them, and prevent the cardiovascular crisis from occurring in the first place, while also ensuring they are prepared for that cardiovascular event when it does occur. We believe that through the inclusion of strategies that have embedded recognition and prevention components, and by focusing on the highly complex dynamics of resuscitating patients in teams, that we can deliver on quality. This is not training. We can deliver on implementation. We now have the technologies to provide the tools to organizations to bring this to life. And we are excited to share this incredible transformation in advanced life support. A card and a file, or a copy of a card and a file. That's what a majority of us know today about the quality of CPR that our healthcare providers are able to deliver. It's a file folder. That's the old standard. We now have advanced analytics where we can evaluate and understand how individuals and how teams respond so we can provide tailored and customized quality improvement feedback to ensure they are optimized for improving the care for the next patient and the next and the next. It's the equivalent of driving blind or driving a jet and having all this information in front of you. We need to bring this to life, and we have created the technologies to do it. It is no longer sufficient for us to believe people do good. We can now know they do good. This is the new standard of care. I am also excited to share that we are bringing to full life and combining with RQI 2020 our ability to be able to capture some of the most critical data that has fallen through the gaps of healthcare. Less than 5% of hospitals in the United States are reporting on the incidence, outcomes, and locations of cardiac arrest within their organizations. It's an extremely narrow set, and we simply do not have a full understanding of what's occurring. We are reducing that burden and creating a limited data set focused on resuscitation, combined with RQI 2020, where we can bring to life the power of this data. So we're not only measuring and improving on the individual level, but we're also measuring and improving on the system level. We all gain from that, and that's a new standard of care. One of the greatest hurdles that we knew we had to overcome, and one of the greatest barriers that's limited our ability to truly provide our solutions throughout the full spectrum, has been technology. We have designed an entirely new platform that is LMS agnostic. And what I mean by that is, we have created the ability to work with any LMS vendor who is willing to work with us to ensure that we can provide our content directly to your providers, directly to your organization. Overcoming what has been years of hurdles of access to care. We consider this to be one of the most tremendous breakthroughs, and we have leveraged technology to make it possible. The burden today on healthcare organizations is unbelievable. I can appreciate as CNOs and CEOs and those in the live stream, we've faced the challenge of trying to find the equity of cost and quality, creating a platform for value to ensure that we are delivering what is right for our patients while simultaneously what is right for the system so we can continue to care for the patients. One of the most incredible insights that we believed that we have now seen is the RQI program delivers on that potential to generate savings. It is a complete change in the paradigm of how we look at cost and how we look at investments. And you'll hear more in a second, but we've had incredible stories from organizations who, when they move to a more efficient model, have generated savings, or who have been able to generate reduction in malpractice insurance rates because they recognize the new standard of care is quality improvement. It's not training. We believe, with what I've shared with you and what you've heard from the speakers before me, that we can and we will deliver on the full life-saving potential of saving an additional 50,000 lives each year by 2025 by creating this new standard of care. You've heard it from me, but now I'm going to ask that you listen to some of our colleagues and our friends and hear it from them.
Every week, every day, every hour that passes by, the world of healthcare transforms. New treatments for new patients with new experiences, new technology, new staff, outside the hospital, inside. Some consider transformation as their responsibility, their obligation. We call them agents of change, our RQI pioneers.
It's been an awakening in terms of CPR quality and resuscitation quality.
We were able to really get buy-in from everyone across the organization.
More resuscitation events are successful, more patients survive, more patients ultimately go home.
We were looking for that next evolution of education for our staff that would keep them at the bedside.
The old training with ACLS every 2 to 3 years is archaic.
As a magnet hospital, we're innovative, we're creative, and we really love cutting-edge technology.
Now we have our peers confidently correcting and coaching each other to provide high-quality CPR.
In early 2014, Texas Health Resources Presbyterian Dallas enrolled 2,100 healthcare providers in the RQI program.
Texas Health Resources chose to implement the RQI program because it was a natural match with our mission, our vision, and our values. It really reflected what we were trying to do in the community, which is to improve the lives of the people that we serve in the communities that we care for them in.
We've seen statistically significant improvements in survival rates from cardiac arrest at our organization since implementing the RQI program.
We were a very traditional model, which meant a lot of time away from the bedside, a lot of time in the classrooms, and a lot of expense on salaries and wages. What we found by implementing the RQI system is that we will save over $300,000 this year in terms of what we would have spent traditionally on the old model.
The program has expanded system-wide at THR with currently over 12,000 employees engaged in low-dose, high-frequency quality improvement. Seton Healthcare, now a member of the Ascension system, was seeking to innovate their resuscitation program.
From the very moment that one of my team members came back from a convention seeing the RQI station, my world was on a new path. My team and I had already been tasked with innovating resuscitation in our organization. From the moment of presenting to our executives in the boardroom, presented the trifecta goals, the 3 goals: associate satisfaction, quality improvement, and cost savings, we immediately got a yes answer. And then from then on, it has been a whirlwind of just enjoying watching the program grow. The fact that RQI is used as the platform for other low-dose, high-frequency approaches throughout our organization, that is huge. It's like RQI brought a new mindset of providing skills, competency validation, and practice and education across the continuum.
Seton Healthcare rapidly accomplished the very first full system RQI adoption and today has nearly 10,000 providers participating. The Ohio State University Wexner Medical Center was the original RQI pilot site and the first RQI adoption anywhere in the world. As an academic medical center, Ohio State took a data-verified approach to quality improvement.
As we started looking at some of our data and looking at the initial attempts with the RQI equipment, the realization that even as seasoned professionals, we got a lot of room to improve. We've got a lot of room to grow. I've been a paramedic for almost 20 years now. And the first time I got on an RQI cart, it was really mind-blowing how much room I had for improvement. I'd say I did great CPR. I can tell you now I do it even better. The low-dose, high-frequency model that's utilized there is very similar to what we see in, say, a music lesson. Whether you're a professional piano player playing multiple concerts a year, or you're an amateur that may only play 1 concert a year, you practice. You spend time preparing for that. And with RQI, we get that same concept with resuscitation.
UAB is the only Level 1 adult trauma center hospital in Alabama. UAB Medicine's emergency physicians are on the forefront of modern medical care, and UAB nurses are honored as Alabama's only magnet hospital.
Like any disruptive technology, we were very concerned when we introduced RQI that there would be some resistance or some hesitation. What we found is that the uptake of the new RQI platform was actually very rapid and the staff was very accepting. My staff now competes to determine who gets the best proficiency to see who can score higher. That is the intangible gold that I can't buy, I can't institute, I can't create through some other means. Well, when you make a change, what you want to be able to see is that you're getting a return on your investment. It doesn't matter if you want to measure it by the dollars saved. It doesn't matter if you want to measure it by the intangible change in culture and the confidence the staff has. It doesn't matter if you want to measure it by lives saved after resuscitation events in your hospital. Any way you measure it, RQI clearly represents a fundamental change in the way we practice resuscitation, and that is a clear improvement over the paradigm that we're using now.
As a research organization dedicated to continuous improvement, the University of Rochester initiated their RQI program as a pilot to study the efficiency of the program with their clinical workforce.
The University of Rochester's mantra is Meliora, which means ever better. And so RQI was for us just that, something that brought to the forefront not only a better educational model, better delivery system for CPR, but we've seen enhanced quality patient outcomes with it.
When we implemented RQI, we didn't just do it for the nursing staff and the adult critical care areas. We were able to really collaborate with our residency program, with our fellows, with our attendings. It also included respiratory care, really anyone who could participate in a code.
I was so impressed by the program and the quality improvement it provided to our patients that I added RQI to the list of quality improvement processes that faculty could partake in that would result in a 15% malpractice reduction for them.
We are indebted to these pioneer leaders who have lit the path and blazed the trail for a new reality in resuscitation. In doing so, they have made the world a safer place, one hospital, one community at a time.
Good afternoon. I'm John Miners. I'm Chief of Mission Aligned Businesses and Health Solutions at the American Heart Association. I want to thank again our RQI pioneers. Without them, we wouldn't be here today. And over the last several years, they've been extraordinarily generous with their expertise, their feedback, and patience as we've refined and worked through our design thinking processes, many sprints and improvements in technology and software and training. We can't thank you enough, and for all the feedback you're giving us that's informed the RQI 2020 solution. We're so excited to bring that to you in January. Now I'd like to invite Nancy Brown and Tor Laerdal back up to the stage, if you will. While they're coming up, I wanted to thank all the rest of you here in the room for being with us this afternoon to hear this important information, and the 2,000 online participants, and we're glad you're here today. So Nancy and Tor, we've spent a bit of time today talking about how the strategic relationship between the American Heart Association and Laerdal is continuing to advance the technology and improve systems and solutions for resuscitation and emergency cardiovascular care. I wanted to delve into that a little bit more so the folks here in attendance and those online really come away today with a clear idea of what it is that we can accomplish and how they can join us in the journey. The first, Nancy, do you really think getting to zero is realistic? It's a bold vision.
John, it is an absolutely bold vision, and it's one we're very dedicated to at the American Heart Association. You know, before someone has a cardiac arrest, there's a lot of things that science needs to help us learn and know. And if you think of the full spectrum of the work of the American Heart Association, we need to better understand why some people who have coronary heart disease, their very first sign or symptom of that is having a cardiac arrest. So our science needs to help us understand that. And we need to do more to help people prevent having cardiovascular disease or any disease that could cause a cardiac arrest. But we know that with the rise of risk factors for coronary heart disease and cardiovascular disease overall in the US and around the world, that more people are likely to have sudden cardiac arrest or a cardiac arrest, not fewer people in the months and years ahead. And it is our mandate at the American Heart Association to bring every resource we have possible to help make sure that every person who has a cardiac arrest has a chance to survive and to thrive. And with the same bold and innovative spirit we've always had at the American Heart Association, we will take this on and we will succeed.
And Tor, you shared in your remarks that even though we've been successful in training, many times we struggle with impact. Can you say more about that?
Yeah, first of all, I'd like again to repeat that this CPR, which has been considered, I think, one of the most significant public health initiatives in the last 2 generations, and have led to saving in excess of 5 million lives over the last 50, 60 years. That's a tremendous success to start. But we know today that even more can be achieved, and that it's not primarily a matter of training and compliance. It's a matter of competence, and it's a matter of quality improvement. And that demands much more of an efficient implementation system, and that is what this new program is aiming at providing.
The change in standard of care that's been proposed today will be disruptive for the American Heart Association and the healthcare industry. Nancy, are you ready to take on the challenge?
Yeah, we're ready. It makes me so proud having listened to Russell and to Brian, not just describe the problem, but describe the solutions that we've already created. And with our partners who are here today that have worked with us tirelessly to refine these approaches, we are ready to go to market and to help every single healthcare provider be not just trained, but have excellent skills that are guaranteed to save a life.
Russell did describe this, opportunity before us. Tor, why is now the right time for RQI 2020?
Because there is new evidence, there is knowledge about things that can work better. There is opportunities to save so many more lives. There is opportunities to save costs. There is much increased attention, for obvious reasons, to patient safety. And poor performance CPR should be considered a preventable harm.
Exactly. So transforming the standard of care will take commitment, energy, investment. Tor and Nancy, what's your commitment?
Well, we have a big commitment today, and Tor, let's announce our big commitment. The American Heart Association and Laerdal, as we have outlined, have been amazing partners since 2005, and we're very proud of all that we have accomplished together. But we recognize that for all of these new solutions, that technology-based solutions, quality improvement solutions that you heard about today from Russell, we must have a new model of working together. And that's why today we are delighted to announce the formation of a new joint venture, RQI Partners LLC, that will be an official formal corporation of our 2 organizations that will allow us to put significant resources and 100% focus and dedication on bringing this vision to life of no one dying of a cardiac arrest and saving 50,000 lives a year by 2025.
Well, I want to express our gratitude and that we're quite humbled to be invited to be part of this alliance with the American Heart Association. We have had the privilege of working together for many years. We have a shared mission of helping save lives, and we are convinced that this can save very, very many more lives. To start with in US hospitals, and ultimately this can grow to the EMS and to internationally. So this is a tremendous opportunity, and I can't think of any more meaningful task than to be invited to achieve that mission together with the American Heart Association. So we couldn't be more committed. Thank you very much.
Let's get to work.
Yes.
Thank you, my friend.
Thank you, Nancy and Tor.
Thank you, John.
For being with us in this conference, and such an important message. This concludes our live streaming event. We wanted to thank all of you for being here, and I hope you'll join us for lunch in the Altitude Room, which is on the 33rd floor. Thank you all again.